Very good afternoon to everyone present here. I'm Dr. Advocacy, Assistant Professor in the Department of Community and Family Medicine, Deoghar. On behalf of the department, it gives me immense pleasure to welcome all our distinguished guests, respected speakers, faculty members, senior and jury colleagues, and all participating to this timely and deeply significant webinar on emerging health challenges of hypertension among Jharkhand tribal communities. Jharkhand is a land of vibrant tribal cultures, rich traditions, and a strong community bond. Yet, behind this strength lies an evolving health landscape. One where non-communicable diseases, especially hypertension, are silently rising, often unnoticed and undiagnosed. In many tribal pockets, symptoms go unrecognized. Access to care remains limited, and cultural and socio-economic barriers continue to widen the gap. Today's session is a collective effort to shed light on this hidden crisis, understand its true scientific and community-based perspectives, and explore strategies that are considerably conceptual, feasible, and impactful. So I request everyone to don't miss any step. The last segment will tie everything together and spark real solutions. Now we are privileged to have with us Professor Dr. Nitin M. Gandhi, Executive Director and CEO of Deoghar. We are grateful that despite his extremely busy schedule, he has graciously agreed to join us today. Sir will deliver the inaugural address, setting the tone for today's day. So over to you, sir. Sir, are you there, sir?
Uh,
I have
Well,
been certain technical glitches.
yeah, thank you. So, Dr. Sudeep Bhattacharya, my colleagues in Department of Community Medicine, and the participants for this particular webinar, which is organized by Department of Community Medicine of AIMS Deoghar. I must say this is one of the important areas, and we have been uh, having a focus on tribal health research. And Dr. Arnav, Dr. Sudeep have taken this forward by not only finding the risk factors and incidence of hypertension among the tribal population, but also to understand what can be the community strategies for prevention and control. I think this will help us in formulating some policies and some knowledge about the problem of hypertension in the tribal population. And subsequently, we can come with some uh, programs which can be also lead to a larger study related to hypertension among the tribal population. So my best wishes again to the department as well as Dr. Sudeep for organizing this activity, and thank you. Dr. Sudeep, you can take over now.
Okay, thank you so much, sir, for your insightful and thought-provoking address. Thank you so much, sir, for your insightful and encouraging message. Your words truly motivate us to strengthen public health outreach in tribal regions. Next, as our main academic sir is busy right now, we will move to next question. He will join later. Perhaps he is busy in certain work. So we have a speaker, we have a guest speaker today. It's my absolute honor and delightful surprise for all of you to welcome a living legend in public health and an inspiring figure for all, not only in this country but across the globe. Professor Dr. Amarjit Singh Sir, former head of the Department of Community and Family Medicine of the School of Public Health, CVI Chandigarh, he will share his reflections. Sir, the virtual stage is yours now.
May I start?
Yes, sure.
Am I audible? Please confirm.
Yes, sir. You are audible, sir.
Okay. Okay, then I congratulate Dr. Sudeep, Dr. Janvi, and Dr. Janvi's team, the Department of Community and Family Medicine in Deoghar for taking this initiative. Really encouraging. And I'll be very brief. Just first of all, I may remind you of Dr. C. Gopalan. Most of you may know he was an eminent nutritionist, I think, director ICM or he was in NIN also. He used to say that if you're talking about any vitamin deficiency, so do not focus on that vitamin alone. Because a single deficiency picked up by a clinician or a health worker is just a reflection of the overall things the body, that person is facing. The same way, today's webinar on hypertension, my personal view is that this hypertension is just a reflection of the macro level changes, the problems the tribals are facing. And I believe Dr. Janvi's session and Dr. Divyanshu's session are going to be the most crucial of today's list of sessions, because Dr. Janvi's session talks about that socio-cultural determinants, and Dr. Divyanshu talks about, I believe, future policy and other things, line of action. Medicinal cure is, to me, is not the solution. I'm not saying that we don't have to give the antihypertensive, yes, but it will not solve the problem. And the macro level things means that if we are talking about hypertension, this just reflects, it is a kind of a package deal. Like that person who is having hypertension may also have obesity, or in future may have their diabetes, constipation, obesity, piles, anal fissure, whatnot. So if we focus on hypertension, that will be what we call blinkered vision or a narrow vision. We should have a broad vision. And I believe you are lucky to have an opportunity of working with the tribals, for the tribals in that tribal area. This opportunity is not with others. And I don't know whether you have heard about a TV serial. There was a TV serial Surbi about 30, 40 years back, in which Siddharth and Renuka Shahane hosted the session. The serial was very popular. In one of the sessions, they went to a tribal area and gifted lungi, the lower wear, that to a chief of a tribal area, because in that tribal area everybody was naked down below. So they gave a red colored lungi, and instead of tying on his torso, the chief of the tribe put on the head like this turban. So we have to realize that before working with tribals, we have to learn from them. We have to unlearn what we have learned through MBBS, MD, or during up to +2 level. First, we have to learn from them. Only then we can do something worthwhile. Like another issue is of a term you might have heard is Sanskritization. Earlier, it was known as Brahmanization. This concept was given by M.N. Srinivas, I think in 1960s, and he said that usually lower caste people try to copy or emulate or imitate the upper caste people to increase their social status. But it may be spontaneous or imposed, as I believe is happening in tribal area. We are imposing our culture on them, and hypertension is a reflection, output of that. And I believe you must have also heard about Hunja tribe, Hunja tea and all that. Some tribes which do not use salt at all. We from urban area, from mainland area are contaminating their culture. So our focus should not be on the narrow aspects. I repeat, we have to go for the macro level changes, and as far as possible, they should be allowed, I'm using the word allowed, to retain their culture, plus the whatever benefit we can provide. But we should not be doing what we call in Hindi, we should not be obliging them. We are not doing, हम कोई उन पर एहसान नहीं कर रहे हैं. That kind of feeling should be there when we work with them. And lastly, my suggestion is that since your institution has a term of AIMS Deoghar, AIMS is a generic term, the focus should be on Deoghar. Usually we talk about SWOT analysis, strength, weakness, opportunity, threat. Some people will say that working in Deoghar tribal area is a weakness or limitation. Rather, it should be the other way around. Among the various aims, Deoghar should stand tall and unique opportunity working with travel. So this initiative really, I think, will take you far. And lastly, just suggesting that Dr. Sudeep, Dr. Janvi, and the team under the leadership of Dean and the director should, I think, come up with a book about tribal health, not just hypertension. And when you talk about the book, if you develop it, contents, the solution will be before you. It will open up itself because you plan the book, so different things will come to your mind. And a 300, 400, 500 page book should be an output, and of which hypertension is just a chapter. So this is just my point of view, and I believe all of you will surely do well. And of course, the name of our discipline, community medicine, community and family medicine, it is because of your work, it will reach to new heights and even up to international level. So my best wishes and congratulations again to the whole team, Dr. Sudeep and all. And Dr. Sudeep, I remember that he has already worked with that use of IT for tribal people long back. So I think he will continue with that along with various aspects of tribal health. So thank you. Thanks for inviting me, and best wishes again. Dr. Abha, you may please continue.
Thank you, sir. On behalf of Dr. Abha, I would and the whole team, I would like to thank you for your such beautiful presentation. And we will surely follow with your advice of book on tribal health. I think there might be some problem with the connection. Thank you very much, sir.
Okay, thank you. Bye.
Thank you so much, Majid sir. So, see you after a long time. How are you, sir?
I'm fine. I'm fine.
Thank you so much, sir. Actually, there was some interruption due to single glitch. Sorry for that. Thank you, sir, for blessing us, and definitely we will come with so many books. We need your blessings for that, sir. With this,
I'm
we
here
will.
to help if any help is needed for the book later on sometime. Okay, thank you.
Thank you so much, sir. Thank you, sir. Thank you so much. With this, we will now moving to the scientific talks of our program. Our first thematic talk focuses on a crucial dimension of today's topic, the socio-cultural determinants that shape health behavior, perceptions, and access to care among population. It's my pleasure to introduce Professor Dr. G. Gandhi. He is student welfare and professor and head of the Department of Community and Family Medicine in Deoghar. He delivered her talk on socio-cultural determinants of hypertension among tribal population. Ma'am, we warmly welcome you and request you to kindly address the audience.
Good afternoon, everyone. So today the topic uh, which I'm going to discuss today is on socio-cultural determinants of hypertension among tribal population. So as Amarjit sir has already pointed out so many things that because of the culture which we are imposing on them and because of all these problems, the hypertension is increasing in the tribal population. So before going into the topic proper, I just want to share my experiences with the tribal population. I had worked in Andaman and Nicobar Islands, where I could say that these people were basically hunters and gatherers, and these people, as Sir has rightly pointed out, they were basically hunters and gatherers, but uh, they were made to stay in one island where they were they were not uh, using that those skills of theirs, and they had to settle down there. And now, because of all these problems, the hypertension is increasing in them, all the NCDs are increasing in them. So now that I'm here also, here in Jharkhand, there is so much of tribal population here too, and we are trying to understand the problems over here along with my team. So here there are many tribal groups, like there are 32 tribal groups and 9 are particularly vulnerable tribal groups. So we are closely working with them to understand the basically why the hypertension is increasing in this population. So as I have already said, there are many tribal groups here, and the our AIMS Deoghar is situated in Santal Pargana area, where 40% of them of the population is tribal population. So now coming into the topic proper, what I would like to point out is it's a quadruple burden of disease over here, and today we are basically talking about hypertension. So overall, 24% of uh, 24% prevalence of hypertension is there in adults overall in the tribal population, but here in Jharkhand it is 31%, which is higher than the national average. So historically, as we all know, that these people exhibited low prevalence of lifestyle diseases, hypertension, diabetes, non-communicable diseases. But because of their traditional diets and relative isolation, and because of their physically active lifestyles. But right now it is increasing, and because of their frugal diet and high physical activity, it was very less at that time, and because of the traditional food. But right now, as Sir has already mentioned, because of the culture, we are basically imposing a culture on them. Plus, there is so much of vulnerability because of their substance abuse and persistent undernutrition during their childhood. So this changing lifestyle in adulthood has integrated into this part of the population, and this is a cause of all the problems. So these basically, what we have to understand is that they basically rely on traditional healers for their illness, and hypertension is often not recognized. And so it is the most neglected part of the disease, and they do not believe in long-term treatment as they believe in their supernatural causes of fate. So what we need to basically do is we have to catch hold of these people whom they believe in, like whom they trust. So we need to catch hold of these people first and make them aware, and then so that they will catch this hypertension early. Previous, they will catch hold of this hypertension early, and we can follow them up, and we can treat this hypertension. And we have to make, basically they need to be made aware, and they need to trust us. And for that, it needs a lot of time, and it needs a lot of interactions with them, which we are trying to do in this part of the country with our AIMS Deoghar team. So what I would like to say is it should be culturally tailored, and we should be the leaders in the community and lead them, and it should be supported by tribal healers. So with this um, short introduction to this theme, I thank all of you very much. And thank you, Sudeep. Thank you, everyone.
Thank you so much, ma'am, for that enlightening session. Ma'am told that how socio-cultural landscape of tribal communities truly help us understand why hypertension manifests the way it does on the ground. This perspective is essential for designing real-world community-friendly intervention. We will now move to our next talk. It is my pleasure to invite Dr. Abhijit V. Boratna, sir. He is additional professor in the Department of Community and Family Medicine in Deoghar, to deliver his talk on dietary patterns and salt consumption users from tribal areas. Over to you, sir.
Thank you, Abha. Good afternoon, everyone. Already we have got certain highlights of the tribal population as well as the problem of hypertension among them. So in continuation of that, I would like to uh, take few minutes to explain regarding the dietary pattern and salt consumption and what we have learned from the tribal areas. Historically, the tribal population in India is supposed to have diverse dietary pattern, nutrition-rich diet, because they were consuming a lot of millets in ancient time. But because of the socio-economical changes and cultural transition, as well as it was back with the Green Revolution in 1960s, where we shifted our diet from millets to rice and wheat. So they have seen this transition, and this whole pattern of the diet among the tribal people also has changed a lot. Now, if we try to understand what type of diet they are taking, what are the dietary habits they have, especially rising salt consumption, what for they are taking salt more in diet, all these things, when we will understand, that time only we will be able to make certain intervention specifically for this tribal population. Now, as we know that historically they were taking very less salt initially, and because of this transition, they have now shifted to high level of consumption. Now it is few studies are saying about around 10 to 12 gram per day they are consuming, because of certain factors. Like they have also started taking packaged snacks, because now in tribal areas also, when we move inside, we will be able to see these packs which are available into small shops also. Then to preserve their food, they are using more salt in form of like salted dried fish or meat or pickles. And they are also using more salt during the cooking. I will tell you why they are using it more in quantity. And there are so many options available for them to have a low cost processed food. This slide shows you there are certain pictures. Like in first picture, if you see that there are two ladies selling homemade alcohol, and along with that, they are also selling certain food items which they are preparing at home with the high salt content. And that is a usual pattern of consumption of alcohol along with certain accompaniments. Then there are certain, no, one picture is there that community meal is being cooked, and there are so many occasions among these tribal people where they are coming together, celebrating certain things, certain festivals, where they have developed the habit of putting more salt to develop more taste into the food. They're also adding salt more into their diet to give more strength. And this is mainly observed in manual laborers, where they are thinking that this salt will give them more strength while working and pulling and lifting certain weights. Children are also attracted towards this salty packaged food, and it is reflecting the market influence in the tribal population. They are also not having that much information about the salt, how it is linked with the hypertension, and what type of challenges they may have if they are getting the hypertension in future. There are other tradition, as I said, that they are celebrating few festivals. Like there are famous festivals into tribal population like Sharhul, Karam, Sorai, where celebrating the spring season or animals. And that time they are involved into mass cooking. So to bring the more taste, they are using more salt. Because that oil, if you see the oil content of that particular food is relatively less, but to add taste or taste enhancer, they are using salt. Then this population, sometimes they are migratory, they are going from one place to other. And there is a problem of dry season also. So when the vegetables are not available, they are using the pickled meat or tubers, they are fermenting along with the salt. And that is going to give them high consumption of the salt. And there is another misconception among these people that this coarse salt in the form of rock salt or senda namak is relatively harmless, or it is safer. So they are unknowingly using more salt in their diet. So to conclude regarding dietary pattern and salt consumption, like as I said, that tribal population in ancient time they were using low salt, but now because of the changing to dietary pattern and various factors, now that has changed to the high consumption of the salt. Then this is giving them high risk for developing hypertension and other complications. And so what we can do is like one sort of strategy we can develop where we can give promotion to millet based diet in the tribal population. They can reserve or they can preserve their whatever tradition of eating the forest foods and implementing the culturally acceptable, socially acceptable food items or dishes which is having less salt content. So this is from me. Thank you, organizers and whole team. Thank you.
Thank you so much, sir, for very informative presentation. The sir told that initially their diets were containing less than salt, but they are also moving towards urbanization using snacks that has high salt. So explanation of local food habits and salt practices gives us a clearer picture of the everyday behavioral risk factors contributing to hypertension in tribal populations. Moving ahead, our next speaker will highlight challenges that often remain invisible but affect thousands. Hypertension may be easy to diagnose in urban clinics, but in remote tribal regions, the pathway to screening and treatment is filled with hurdles. So, to take us deeper into this critical issue, it is my privilege to invite Dr. Richard, Additional Professor, Department of Community and Family Medicine, Deoghar, to deliver her talk on barriers to hypertension screening and treatment in remote areas. Ma'am, we welcome you to address the audience.
Thank you, Dr. Abha. So, a very good afternoon to Amarjeet sir, respected our HOD madam and all the colleagues of CFM Department of AIMS Deoghar. So, I'll be talking on barriers to screening and treatment to hypertension among the tribal communities. So, it's a well-known fact that these tribal people, they are traditionally and culturally different from rest of the population. They have a traditional lifestyle, and but the studies are showing that the prevalence is rising among them. So the barriers to these prevalence is like next. These people, they are having hypertension, but they have got barrier to access to the services, to the access to screening of hypertension. The reasons being the geographical isolation, their socio-economical and financial barriers are there. They have less awareness because of the gender and the socio-economic inequalities, the health system limitations, the cultural barriers, and also the changing epidemiological risk. Next. So many tribal people, we all know that they live in remote, hilly or forested areas where the connectivity with the road is very poor, and it is very difficult for them to reach the health centers. Moreover, the PHCs and the subcenters in the tribal regions, they are often undersourced, and there are shortages of medical staff, diagnostic tools, essential medicines, and even equipments which is required for the disease management. The tribal people, they are generally not aware about hypertension. In a multicentric cross-sectional study among tribal population, it was only 27% of the hypertensive individuals were aware of their status. And they have a very poor health literacy in the limiting the understanding of the silent disease like hypertension and diabetes. And cultural beliefs, their reliance on the traditional medicine, and trust in spiritual healers also diverts them from the biomedical screening and treatment. Next. These people, they are poor, they earn less, and when they have any disease, they have got out of pocket expenditure, and that leads to the loss of wages and again a financial burden for even a small disease. And so when they go for a screening? They don't even go for the treatment of smaller diseases because they are poor and they have got out of pocket expenditure, and that is a vicious cycle and a major financial burden on them. Next. As mentioned before also, the human resource constraints, poor continuity of care, weak referral systems, and the program implementation gaps is an important limitation for screening of the tribal population for hypertension. Once they go to the now when these tribal people, when they come to the health centers, they have got a big issue of language and communication. There is also social stigma and discrimination, and mentioned earlier by Abhijit sir and Janvi ma'am that their dietary habits are different. They follow certain dietary habits, and because of that, they do not go for the treatment which is advocated by the doctors at the PHCs and at the CHCs. Next. There is also evidence of sex and wealth disparities in hypertension care among the tribals. In Odisha, there is in a study conducted in Odisha, the awareness, treatment, and control was significantly lower among the poorer individuals, and men faced particular barriers related to health seeking. And social determinants like education, income, they also affect the care cascade. Next. Modernization, as mentioned by Abhijit sir, the modernization and the acculturation is increasing the risk factors. These people, they are adopting sedentary lifestyle, obesity, alcohol intake. But the health system is not yet fully prepared to handle this surge. And there is also an inadequate data on surveillance because the tribal population is diverse, dispersed, and systematic screening and follow-ups are challenging among these population. Next. So what we need to do, we need to improve the functionality of the health and the wellness centers in the tribal districts. We need to leverage local languages, traditional healers, tribal cultural forms to improve the awareness and the treatment adherence. We need to have a culturally tailored salt reduction and alcohol and tobacco reduction messages. We need to have uninterrupted supplies of antihypertensive drugs, which are often lacking in the tribal villages. And the village level drug depots should be managed by ASHAs, which can reduce the distance barrier. Next. We need to emphasize on the behavioral and the lifestyle barriers, that is replacing the refined grains with your millets and promoting your low sodium diets with the traditional tribal food system. The tribal subsidies and the reduced out of pocket expenditure is also essential, as the cost barriers hinder the chronic care in the tribal areas. The displacement, the deforestation, and the livelihood insecurity increases the psychological stress, which is a recognized driver of hypertension in the tribal communities. Next. I would like to conclude that we need a dual strategy, that is strengthening the health system while generating your contextual evidence. Policy solutions must be culturally sensitive, geographically accessible, and socially inclusive. And the research must be tribe-specific, participatory, and action-oriented to ensure equitable hypertension control. So thank you all of you for being a patient listener. Over to you, Dr. Abha.
Thank you so much, ma'am, for that eye-opening session. Your presentation really brought to light the silent barriers, geographical, cultural, socio-economic, and gender biases and systems that prevent timely hypertension screening and treatment in tribal regions. These insights remind us how important it is to examine lasting and Thank you so much, ma'am, for your kind words. We now move to a topic that lies at the foundation of all NCD prevention before our first line was. It is my privilege to invite Dr. Vinayaka Murthy Gopal sir. He is Associate Professor in the Department of Community and Family Medicine and Deoghar. He will deliver his talk on role of frontline workers in NCD prevention at the grassroots. Sir, we warmly welcome you to take the session forward.
Thank you, Dr. Abha, for the introduction. Good afternoon, all. I'll be talking for the coming 7 to 10 minutes on the role of frontline workers in NCD prevention at grassroots. It has been already stressed the burden of non-communicable disease. Non-communicable disease contribute to 74% of the global mortality, and in India, of the total death, 63% is attributed to non-communicable disease. Among the various non-communicable diseases, hypertension is the most commonly prevalent. Reducing the NCD burden requires significant investment at the primary healthcare level. And when it comes to health system, one of the important component of the health system is the health workforce. And World Health Organization estimates that by 2030, there will be a global shortage of 11 million healthcare workers at all cadres, starting from medical officers and specialists till the grassroots level workers. And this happens especially in low and middle income countries. Considering this situation of huge burden of non-communicable disease and the shortage of health workforce, investing in frontline healthcare workers especially to tackle this non-communicable disease will be the most effective and cost-effective service. Let me clear who are these frontline health worker. Frontline workers are otherwise called community health workers who are involved in delivering services in areas with limited access. World Health Organization defines frontline workers as those who live in the community they serve and have less formal training compared to doctors and nurses. In India, frontline workers are often women from their own communities. There are two cadre of workers involved in the Ministry of Health and Family Welfare. Number one, ASHA worker, and then number two is ANM. ASHA workers are part-time workers who are trained volunteers. Mainly, they are the one who bridge the community and the health system. ANMs work at sub-center with training in midwifery and MCH. They play mainly a supervisory role and oversee various health activities. It has been well known that ASHA and ANM have done an impactful work in reproductive and child health services. However, the ASHA and ANM involvement in delivering non-communicable disease services is not well studied, especially in India. When it comes to providing service to non-communicable disease, it's unique that non-communicable disease require a continuum of care, which starts from preventing the various lifestyle-related risk factors, and then early diagnosis of people having disease, especially through community-based screening. And after confirming the disease, we need to initiate the treatment timely and then providing access to appropriate medicines, following the patients, follow them for treatment compliance, and also the complications of non-communicable diseases. Thus, we need to provide a lifelong care to these patients with non-communicable diseases. So when we talk about involving frontline workers to deliver healthcare service related to non-communicable diseases, they need to be involved. Actually, they can be involved in providing healthcare service to people with non-communicable diseases along this continuum of care. Let me start one by one. Number one, how these healthcare providers can be involved in health promotion or health education measures. Ashas and ANM being a part of the community, they have a good access to people. They have a good rapport with the people in the community. So already in the system, we have there are already developed community level forums which are existing in the system. For example, village health sanitation and nutrition committee, which are functioning at a primary health center and health and wellness center sub-center. So ASHA can utilize this structure to educate people. Apart from Village Health and Sanitation Committee, we also have Mahila Arogya Samiti and Jan Arogya Samiti, which are part of the villages, and they can be involved to mobilize people for providing for screening treatment, for screening them for initiation treatment or other purposes. Also, villages have youth clubs and local bodies in most of the tribal and rural areas. Asha, being a part of the community, can very well involve them in prioritizing healthy behavior and also prevent non-communicable diseases. When we involve when we involve ourselves in health educating people, especially in the tribal area, the major problem that we encounter is the language. There are different tribal communities having a different sets of language. So that's one of the barrier for us to deliver effective health education session. Asha, being a part of the community, she definitely knows the language well. And another problem of us is building a rapport with the community. So Asha already have a good rapport with the community member, and she has a good trust with the members of the community, and she has got link with all community leaders and other influential people in the community. Thus, this is a good opportunity for the Asha to deliver health education messages which are in local language and will be familiar for the people. And she can use this kinship networks to enable stronger influence and change behavior. And Asha, being a part of the community, very well know the various cultural events which are happening where people gather, and that she can utilize that opportunity to deliver health education message, especially through village leaders and traditional healers to make community decisions. And she knows very well about the myths and conceptions and the culturally appropriate ways of educating people, maybe through storytelling, proverbs, and analogies. She can educate. She can effectively change the awareness level of the people, thereby changing their attitude and behavior. Coming to risk factor modification, our previous speakers have already mentioned the various risk factors that are very specific for tribal population. Commonly, the alcohol use. It's very well known that the alcohol use is culturally acceptable, and in various rituals, the alcohol being consumed commonly by tribal people, which is one of the common risk factor for all NCDs, including hypertension. And number two, tobacco usage. It's again the prevalence of tobacco use among tribal population is double that of the use of tobacco in general population. And salt consumption. Dr. Abhijit has very well explained how increased salt consumption happening in the village in the tribal setting. So Asha can help families reduce salt intake and limit ritual alcohol consumption for hypertensive members. She can engage village leaders and traditional healers to promote NCD-friendly behavior norms. She can even involved in when get trained. She can be a good counselor in counseling people who use tobacco to quit tobacco use. She can encourage daily physical activity through working groups and culturally acceptable routines. And very well, Asha can promote simple, low-cost dietary changes like more vegetables, millet usage, and less fried food, which by that way she can very well be involved in reducing the risk factors of non-communicable diseases. Coming to the screening and diagnosis, Ashas are often the only person who will be reaching every households in the tribal villages. When she goes for the RCH, when she goes to villages to provide RCH related services, she can carry a blood pressure apparatus, and then she can screen for people who are at risk, and she can very well detect the people with hypertension. And frontline workers identify high-risk individuals using close community familiarities. Asha, a part of the member of the community, knows very well about the village people, and she knows who are the people who are consuming excess alcohol, who are the people who always use tobacco, and she know people who are in migration stress. Most of the time, tribal people migrate from one place to other in search of a job. So that actually, that limits these people who frequently migrate to get their blood pressure checked, to know their blood sugar level, and getting drugs on time. So these all can be identified by the Asha. Since she is an insider, she use her intelligence to help people in avoiding getting treatment and getting screened for hypertension and various other non-communicable diseases. And what tools Asha can use? Asha, being educated up maximum up to 8th standard, she can use questionnaires which are easy for her to administer. Once she can be trained, she can use these questionnaires to identify people who are at risk. She can screen people at community level. If Ashas are trained, there are studies which are one of the study which has been in Chhattisgarh, where they have trained Asha workers to use BP apparatus and train them to check blood pressure with minimal error. And so if that's not possible, even a digital BP apparatus with higher accuracy can be used for screening by ASHA worker. People who are already confirmed diagnosis, she can screen, she can check how regularly they're consuming the treatment that have been prescribed. So thereby she can help identify people who are not taking the medications regularly. And she can also be involved in screening people at all levels, starting from the community as well as opportunistic screening, self-screening. She can train people to get screened. So these are the ways by which ASHAs can be involved in screening for common non-communicable diseases. Coming to treatment initiation and follow-up, ASHA cannot initiate treatment. However, ASHA can facilitate people to avail telemedicine service. Those people who are diagnosed with high blood pressure, she can help them to utilize e-Sanjeevani service. And also, India Hypertension Control Initiative has developed an mobile application which is called Simple App, and that helps people to initiate treatment using telemedicine service. ASHA can conduct home visit across scattered hamlets, often walking long distance with BP machines. Thereby, she can know people who are started on treatment, whether their blood pressure is controlled or not. If not, again, she can refer them. ASHA can also help people in self-management, especially dosing the drug, what foods to restrict, and she can help people to recognize warning symptoms. Thereby, she can refer them timely to avoid complications. ASHA can also help them in monitoring and delivering medications, and she can educate them to frequently check for blood pressure and blood sugar. She can help people track progress and make referrals through not only through application, also via phone or by simple messages. Thereby, she can help people in treatment initiation and long-term follow-up. Finally, I will be telling how she can help various other components of the health system so that proper NCD care can be provided. Number one, one of the important pillar of the health system is monitoring and surveillance. So ASHA can definitely help in collecting information, recording them, maintaining various registers, thereby transforming the information from village level to the district and the state level, which helps of performance of the NCD program in these settings. She can bridge gaps in medicine delivery. Whenever there is a stock out in the center, she can, with help of her contact, she can get drugs from nearby centers. Thereby, she can be she can help people in giving uninterrupted treatment. She can ensure continuity during migration. She knows people who are frequently migrating so that she can provide extra drug buffer stocks to those people who are involved in frequent migration. Thereby, she helps them to get uninterrupted supply of drug. She can promote adoption of digital health tools using tablet phones and feeding the information in the portal. And another important thing, building trust. Most of the time, people in tribal settings have distrust in the system. So ASHA can help people to build trust so that they can avail the service to improve their health status. Coming to the factors, till now we have seen what are the various roles these frontline healthcare workers can provide to prevent and control non-communicable diseases. Let's see the factors which are involved, the favoring or hindering factors. And I've classified them under 4 headings. Number 1, related to the patient, related to health system, factors related to the technology, and patients factors related to the healthcare worker. When it comes to patient factor, health literacy of the patient, the other comorbidities, their amenability to self-checking, access to healthy food and physical activity facilities. These are the factors which help, which promote people follow the advice given by the healthcare workers to improve their health status. And health system related factor, mainly adequate supply. Apart from the ASHA working properly, if supplies are inadequate, that again hinders the service. So adequate supply, support from healthcare, various other healthcare providers, the relationship with ASHA has with other healthcare providers and with the people, privacy and security of the information which is available with the system, and transport services. These are some of the factors. And technology related factor, mainly availability of smartphones, internet connectivity, and digital literacy of the worker and the patients. Finally, healthcare worker related factor, mainly the level of knowledge and skill, their anxiety, confident, fear, and then information overload. The ASHA is, though, since ASHA is providing service related to other services, so the information that one need to know. And then the increased workload. Apart from NCD, ASHA need to provide various other comprehensive primary healthcare services as well. So these are the factors together will decide how effectively ASHA can provide healthcare service to prevent non-communicable disease. Thank you for people who are patiently listening, and I thank the organizer for giving me an opportunity to talk on this topic.
Thank you so much, sir, for that wonderfully insightful.
Your emphasis on the pivotal role of ASHA, women, and other grassroots workers truly highlights that the success of any program ultimately depends on the strength of those who work closer to the community. To nicely explain the continuum of care they provide at the level of community. From the human touch at the grassroots, we now shift to the power of digital innovation. I am delighted to invite Professor Sunil Kumar Pani, Assistant Professor in the Department of Community and Family Medicine and Further. The overall talk on digital health and telemedicine for tribal hypertension countries. Sir, the platform is yours.
Thank you, Dr. Abha. Thank you, Janvi ma'am, Dr. Sudeep, the organizing team, for giving me this opportunity for presenting this topic. It's very close to my work and heart also. So starting the topic, digital health and telemedicine for tribal hypertension control. So just to take a brief backward step, just to remind myself, 3 years back when we joined the institute, I knew about telemedicine and digital health, but I was very skeptical if it can be ever applied to a tribal population like Jharkhand, where we have dominant tribal population. But throughout my last 3 years of work, and when I had opportunity to see closely the program and others, so I am very confident that digital health can be one of the solutions, if not the whole solution. So tribal hypertension, the pain points remain with all the information given by all the previous speakers. The prevalence is increasing over the years. Tribals are the most vulnerable of the vulnerables. The prevalence ranges from 16 to 23, but our own studies, small student studies in tribal areas, studies done by Dr. Richa ma'am and others, it has shown very high prevalence in some of the pockets of the tribal population that we have encountered. There is a rising prevalence among tribal population in last 2 decades. If we compare NFHS 4 and 5, there is a clear tendency or trend of rising tribal hypertension in various states. Significant high risk among old age tribals. As the age progresses, everybody is prone for all the NCDs. Tribals, some of the studies have shown the old age, more than 60 years, are having 5 to 6 times more risk of hypertension and related comorbidities than 30 years or 35 years of tribal population. Then urbanization. Those tribals which we used to think as tribals, they used to reside in isolation inside jungles. Now the story is different. Many of the tribal communities are residing peri-urban or urban slums. Their locality has changed. With that, their occupation and food quality, type of food. So that urbanization of tribal communities has increased the risk of hypertension, and many of the studies have shown that peri-urban tribal hamlets have higher hypertension prevalence than the tribals who are residing in isolation. Then culturally, many of my previous speakers also told about how high salt consumption had their cultural roots to the tribal form of food preservation, because salt was used since hundred of years for food preservation in many of the older community, including the tribal communities. My first test with this happened with one of the case given to one of the students, where the student calculated and came to me. It was a tribal boy with tuberculosis. So he calculated twice and came to me dumbfounded. Sir, the salt consumption is coming around 25 gram. I was also surprised. That was one of the first cases we encountered in the community. So we calculated again with the same rough method of family consumption of salt within 1 month, and we divided per capita. We calculated the per capita consumption. It was coming around 25-28 gram per head of a family of 4 persons. So that was very high in terms of what we read or what we preach. Next. So, to my mind, with my experience of last several years, hypertensive tribal patient means you have to understand it. So, the first thing is they may be introvert. They first like, then they listen. It's not like us when we listen first to someone and then we develop a rapport, and then we are guided by their advice. You first have to engage with them to make them listen to you. So it was also the first it was put on words by our honorable tribal health minister Arjun Mundaji in one of the tribal health summit in Ames Deoghar, when his first sentence to all of us as a long time tribal leader was, "Do you know tribals?" We were not, nobody could answer. Then Sir told himself, if you are dealing with tribal, you have to think yourself that you are dealing with a community of introverts. They don't engage with you first. You will have to make all the efforts. Then while engaging, the language is 90% of the communication. It is not always Hindi. Even in the Hindi heartland, tribal language differs every 10 kilometers. They undertake difficult transport before they reach you. So if you are finding a tribal person with hypertension coming to your OPD, you must see his hardship throughout the day he or she made just to reach you. Then they are less amenable to convince that there can be a disease of lifetime, which needs a disease, which needs a medication of lifetime. It's very difficult to convince them. And the last thing which bears on all our health system is the trust factors that tribals have, especially on the public health sector. Next. So telemedicine in last 5 to 6 years has been gaining momentum as a last mile service. So many of the PHCs and CHCs of the tribal dominated areas of Jharkhand, in our experience, and in other states also where I have worked, especially Chhattisgarh, Odisha, and Maharashtra, the vacancy of manpower is huge. Recent media reports suggested, and recent reports also suggested, vacancy of doctors alone in Jharkhand, especially in tribal areas, are up to 40%. They may range from 20 to 40%. There is an obvious lack of transport facility in many of the areas. In this scenario, I feel, and telemedicine can be one of the solutions of the service delivery. Next. So the recent NCD program, NP-NCD program, has demarcated all the services that can be given through a telemedicine or digital health intermediaries, where all our field workers like ASHAs, ANMs, and CHOs, they can be digital health intermediaries. So ASHA in the village level, they do population enumeration and risk assessment through CBAC forms, like just told by my previous speaker, which is followed by the ANM checking the BP in regular intervals. In fact, every monthly camp is being conducted in many of the villages. And the data is supposed to be entered in the NCD app, and then that is to be followed in PHC and CHC level through NCD portal and the whole telemedicine or digital health initiatives have to see the patient is referred properly on time and referred back to their village and get the medicines required for the whole time. So ASHAs, as we all know, we put a lot of hope on ASHAs, ANM, and CHO, but they deal with a lot of programs. What we have understood in our work, ASHA work in a pattern of hop on, hop off uh, program services. Like every month comes with a program initiative. So this month is LCDC for leprosy. So next month will be for some other program. Some month for DEC distribution for filariasis. So our recent small scale studies have shown they have very little time to focus on individual diseases, especially NCD. But the works through the screening of NCDs has been gaining momentum, and we hope this improves in the near future. Next. So health workers, how does it work? So when ASHA fills the CBAC forms on the basis of the risk factors that are enlisted in the CBAC forms, ANM enrolls the patient. The patient can directly walk to the Ayushman Arogya Mandir that has been recently converted from the health and wellness centers, referred by ANM. So initial assessment through BP check and examination can be done by the CHO to refer further to nearby PHC, primary health center, or CHC, where the MO has to decide if the patient is hypertensive and to put on treatment. After the patient is put on treatment, he has to refer back to the patient to the CHO, where medicine is being given regularly, and only when the referral is required, the patient has to come to CHC. And the whole referral pathway and the treatment management thing has to be updated in the NCD portal. Next. So what do all health functionaries do in their part? So ASHA is especially responsible for filling up the CBAC form, where all the risk factors of hypertension, for that matter, all the NCDs are assessed, risk assessment is done, and it is entered in the NCD app. The ANM does the BP measurement by house to house screening, and sometimes in many of the villages they do in camp mode, and then they ask the patient to come to CHO, to the Ayushman Arogya Mandir OPD. Then CHO deals with the confirmation of BP, and she decides if the referral has to be done or the patient has to be followed up once or twice more just to decide if he is hypertensive or not. And then it is the medical officer's job to decide if management has to be started or not. So this is how the NCD program works for hypertension control and diagnosis. Next. The eSanjeevani portal works for the teleconsultation. It is for all sorts of teleconsultation, but for NCD also, it is very helpful. And recently, I have seen its use in tribal hamlets by CHO for teleconsultation. So there are two types of eSanjeevani. One is self referred eSanjeevani consultation, where one person can verify its mobile number through OTP, through filling patient registration form. He or she can log in and then select the OPDs, nearby OPDs, to initiate the video call, and he or she can do a teleconsultation in fixed times. The times have been put up in the eSanjeevani site itself. The next assisted telemedicine. Yes, assisted telemedicine for hypertension, which is especially in use in tribal areas of Jharkhand. They've started using it. So here a patient comes to Ayushman Arogya Mandir, referred from by the ASHA. Then there the CHO decides and confirms whether it has to be teleconsulted. So the Ayushman Arogya Mandir serves as a spoke with more than one hub. One of the hub is the nearby CHC or PHC, and the second or third hub may be nearby district hospital and a tertiary care hospital. So in our area, all the Ayushman Arogya Mandir have at least four hubs. One is AIMS Deoghar, second one is RIMS Ranchi, the State Medical College of in the capital, and third one is district hospital. Fourth one is the nearby CHC. So the CHO can contact or raise a teleconsultation to any of the available faculty which is shown inside the eSanjeevani app. And then if required, if it is a teleconsultation of CHC or DH, they can ask the patient to come if the examination findings and other lab findings are not clear. Or else, if it is pretty clear that the patient has to be put on medicines, they can directly tell the CHO to start the medication and call for follow-up. This type of assisted medicine actually put the onus on the CHO and ASHA, because they are the only intermediaries who work between the patient and the medical officer who is sitting in a faraway place. So here the language, the attitude, the behavior of the Ayushman Arogya Mandir, their own attitude toward the community, everything works. So we have seen among 5, 6 Ayushman Arogya Mandir, one or two are doing exceedingly well because they have a very high connect with the community. So this can be leveraged by other Ayushman Arogya Mandirs also. Next. So advantages of teleconsultation for hypertension diagnosis and management resides in improved access to care, where we know that at least 30 to 40% human resource is lacking in many of these areas. There can be remote monitoring of blood pressure, timely medication adjustment. Then we can have patient education and support to the patients, and even we can have trainings for CHOs and others for the same. But the challenges lies in limited internet connectivity in many of the Ayushman Arogya Mandirs, where they use their own mobile internet to use it. I mean, to tether, using the tethering device to start the teleconsultation. There is a obvious language barrier if the CHO, because inside the state also, uh, many of the CHOs are city trained and they are not from the same community. Even from Jharkhand, in one of the Ayushman Arogya Mandirs, the CHO may be tribal, but she is trained in she has a residence in Ranchi, the capital, and was trained in English medium schools. And even if she is a tribal, she has a difficulty to connect with real tribals. So the language barrier and then tribals difficulty using the technology where the physical contact is not there is a factor. And there is an obvious factor for data privacy concerns. Next. So in my view, Ayushman Arogya Mandir will be a future digital health hub for NCD management to deal with this human resource constraint. This is important for early risk stratification, electronic health record maintenance, remote diagnosis confirmation, remote monitoring, remote life-saving medicine delivery, and early diagnosis of adverse cardiac events of NCDs such as hypertension. So the golden hour never applies for tribals that we know. The golden hour for stroke management and other adverse cardiac managements are only for those who reside near a tertiary care hospital. So only the digital health can ensure that golden hour is kept properly for the tribal patients. Yes, next. So our own efforts have included establishment of telepathology in one of the tribal dominated CHCs in our rural health centers, where we have started telepathology for TB patient, not exactly NCD patients. And then the recent trial runs of drone have started with the help of chairmanship of Dr. Abhijit sir in our from our department in AIMS Deoghar, that can be utilized for essential medicine supply to many of the tribal areas. That is also under consideration. Next. So thank you for your patient listening. That is all from me. Thank you, everyone.
Thank you so much, sir, for that forward-looking and inspiring question. Your talk shows how technology can break digital barriers and bring quality health care, even to the remotest corner in tribal states like Jharkhand. Moving from technology-enabled care, we now turn to insights from real-world clinical practice. We now invite Dr. Sushil Kumar, Assistant Professor in the Department of General Medicine in Deoghar, to deliver his talk on experience caring of hypertension management in open and tribal population. Sir, we request you to kindly continue the session.
Thank you for your kind of information, Dr. Abha. A very good afternoon to all of you. So today, in next few minutes, I will going to share my personal experience regarding the treatment of hypertension, particularly in tribal population. As we all know, hypertension is a major risk factor or risk factor for congestive heart failure, morbidity and mortality of the cardiac disease. It is the major risk factor for the stroke, chronic kidney disease, end stage of the renal failure. So it should be managed properly. Or right now there is, or most of the patients of the hypertension usually asymptomatic. They don't have any symptoms. Very few have like symptoms like headache, insomnia, palpitation, but very few, most of them have very asymptomatic. Particularly in the tribal population, there is increasing in incidence of the hypertension. Why this is happening? Because there is increase, as we have seen, in there is increased consumption of alcohol, tobacco, or right now in our region, most of the people in like Ranchi, Dumka, it is urban region, or most of the people there is residing in tribal people. So there may be urbanization in tribal population, and there is increased consumption of the salt, decreased consumption of the potassium, and there may be increased incidence of obstructive sleep apnea. This is the recent most important factor for the increased incidence of the hypertension. So we have to. So I have shared the in OPD 2 or 3 months, a 53-year-old lady named Sunita Hasda from Dumka came to us for presenting complaint of the low back pain. So on screening, we have found that her blood pressure is increased, and then we again measure his blood pressure to take all standard of procedure, and you visually ensure कि patient before taking the blood pressure, we ensure that patient usually take at least 5 to 10 minutes of the rest. She doesn't take in last 1 hour, doesn't take any coffee, tobacco, doesn't have any exercise. She empty her bladder or her sit comfortably on the chair, and at the same time, during the measuring the blood pressure, she is not talking and also not communicate with mobile. In that cases, we may get pseudo hypertension. So after that, we are getting the her blood pressure is 164 by 90. So I have asked them, "Ki your blood pressure is high and you have to go for certain lifestyle modification and you have to also take certain drug." Then she was very surprised. Ki, no, I don't have IF. So usually I here come to my presenting complaint is low back pain. Why I am taking to antihypertensive drug? When I will consult, I have consulted them. Ki blood pressure definitely you doesn't have any symptoms regarding the hypertension, but if this blood pressure in long time, it may leads to certain complications like hypertensive heart disease, end-stage renal failure, or stroke. So after proper before prescribing the medication, we are usually give certain investigation to rule out secondary causes of the hypertension like diabetes mellitus, chronic kidney diseases, renal artery stenosis like CBC, LFT, KFT, ECO, ECG. So after on follow-up, she doesn't have any abnormal lab parameters and she has primary hypertension. So we have usually prescribed certain lifestyle modification like uh, taking low salt diet food, increased consumption of potassium containing food, relieve sleep pattern, weight loss, or proper exercise, walking. And at the same, we have also prescribed him to 5 milligram amlodipine because in cases of old age or essential hypertension, amlodipine is choice of the drug. Or on follow-up, another follow-up, say her blood pressure is normal or she doesn't have developed any complication. So my view is that hypertension is doesn't mean any patients comes to you with hypertension or we just prescribe to antihypertensive. We also have to counsel them why there is need of lifestyle modification, there is need of taking antihypertensive drug and proper follow-up should be very important because if most of the patient doesn't have any symptoms, so after some time they spontaneously stop the medication. In that cases, there may be chances of stroke, particularly in this winter season. So treatment of the hypertension is very important on by taking these small steps and manage hypertension properly. We reduce the burden of the chronic disease like chronic kidney disease, very severe disease, which has very high morbidity and mortality, like stroke and chronic kidney disease, hypertensive heart disease, peripheral arterial disease. So this by this all words for kind of I conclude my talk and I again thank you for organization and Dr. Sudeep to giving me opportunity to this talk and thank you for your patience listening. Thank you.
Thank you so much, sir, for sharing such practical and experience-rich insights. Hearing how hypertension present and is managed in everyday routine setting, giving us a clearer understanding of clear certain behavior challenges, opportunities for improvement. We see that simple, small steps like lifestyle changes, compliance to treatment are very important. Now, as we move to final thematic session, we turn our attention to the bigger picture, that is policy direction and research planning. It is my honor to invite Dr. Divyanshu Singh Ma'am. She is Associate Professor in the Department of Community and Family Medicine in Deoghar to deliver her talk on policy and research priorities for tribal hypertension. Ma'am, we look forward to your valuable perspective.
Thank you so much, ma'am. Very warm welcome to all and good afternoon. And thank you so much for giving this opportunity to me for speaking. Can you please start sharing my slide? Yeah. Next slide. So I'll be speaking on the policy and research priorities. By now, all of us know that the tribal populations, they have their own traditional lifestyles. So according to that, whatever healthcare access they have is not very great. And the studies have shown that there is the trend is rising prevalence of hypertension. That is why we are conducting this webinar and we are speaking on the topic. So the rising hypertension is basically due to the changing lifestyles, as we have seen, as covered by Dr. Janvi ma'am. She has spoken about the topic, like how the lifestyle has changed these days. They also have limited healthcare access. There are certain socio-cultural barriers, and there's systematic inequities also. So we are now by now we understand that uh, effective policy and research strategies, they need to be framed for this tribal context. Till now, whatever the policies have been framed, they have been framed according to the rural and urban population. So in National Health Mission also we have according to the rural and urban, and whatever tribal population was there, it was covered under the rural part. So now we have seen that since there is a rising trend and tribal population is also equally important for us, so we need to frame definitely a different policy for the tribal population. So we need to have a separate tribal health mission. So this is how, please next slide. So this is how we will be talking about it. Next slide. Can you please change the slide? I think there is some issue in the net.
Sorry, ma'am. Perhaps there is some technical glitch.
Achha.
It's not audible.
Okay. So should I
Yes,
continue
ma'am.
speaking?
Yes, ma'am.
The
You
slide
are
is
audible
not
right
able to change.
now.
Pardon,
Yes, ma'am.
ma'am.
You are audible right now.
So the slides are not able to change. So should I continue speaking, ma'am? Okay. So let me
Ma'am,
continue.
if you have the slides, you can continue. Actually, there is some glitch here. We are not able to move the slides. Right. If
Okay,
you have
fine,
the
ma'am.
slides,
Yeah,
okay.
I will share from my side. Thank you so much. Is my screen visible to all?
Yes, ma'am. Your screen is visible.
Okay,
You can
thank you.
continue, ma'am.
Okay, thank you so much. So, as Dr. Richa has already discussed about the behavior, there are certain barriers, behavioral and lifestyle barriers. So, we all of us know what are those barriers, and we need to get over them. For those, we have to identify those barriers which we have already identified with, and if we have to frame the policy, what should be our policy priorities. So, I would like to advocate for that there should be a separate, dedicated tribal NCD mission. So we should develop definitely a separate tribal NCD mission for Jharkhand, because the tribal population is remarkably great here, and we should also focus on improving the functionality of health and wellness centers in tribal districts. Why? Because health and wellness centers, they are situated at the peripheral level, and that is the place which is actually little bit accessible to the tribal population. They're not able to always come to the block level or the district level. So since if the population is at the health and wellness centers, if we equip the health and wellness centers well, then it will be of great help in the control of the hypertension and non-communicable diseases. So apart from that, the local languages promotion and teaching the traditional healers, like we should involve them. Why we should involve the traditional healers? Because they are the first person where people go. So in our policy, like similarly, like in MCH, we have done that. We to make MCH part successful, what we introduced TBAs, traditional birth attendants. We introduced them who are already present there in the field. We trained them for proper delivery. So like that, traditional healers have to be trained so that they can identify, they are the first person whom the tribals contact because of their trust. So they should be trained well to identify hypertension and for the treatment as well. So as, and also because they are more close to the tribal cultural norms, they know how to approach them well. So this is how. And then also what is important is that whatever messages we are framing in our policy, that should be culturally appropriate, and it should be tailored around their customs and tradition. As all of us know that alcohol is a part of their tradition. So, like Abhijit sir mentioned that now they have switched on to the locally available snacks. So we have to again train them to go back to their own traditional thing, which was actually low salt, and it was high fiber diet also. So first, also research priorities are there, which we have to take care of that. So what are the research priorities? That we have to first check what are the Jharkhand specific hypertension cutoff for the tribal population. As all of us know that whatever the JNC criteria we have, is it actually really applicable for this population also? That we need to check. For that, we need to conduct longitudinal cohort studies which are based on tribal cardiovascular health. So for this, funding is also required. So we need to prioritize this field. Like for the research has to be prioritized. So we have to expand the behavioral economics research in tribal settings so that the further research can be done, and accordingly the policy can be framed around that, right? So we also need to incorporate the indigenous dietary research. Diet is a very important part for the control of non-communicable diseases. So once we do this dietary research, this can be incorporated in the state guidelines. So whatever guidelines, till now what is happening, that whatever guidelines we have for the rural and urban part in this non-communicable disease NP-NCD, we have a part for the tribal population as well. When we go and see the policy, everywhere there's certain part for tribal population. So this can be incorporated in the state guidelines, whatever we are doing for the tribal people. So basically, whatever policy we frame, what are we going to check it? That what are the deliverables? What we want to see? That this has already been covered. That what we need to do? We need to mandate annual BP screening and establish mobile NCD vans. So these are the things through which we can achieve whatever we want to achieve. So establish mobile NCD vans for hard to reach hamlets, integrate hypertension screening with forest rights and livelihood programs. Why? Because most of the tribal population is based in forest area. They are not also covered in the rural area. Also, this has been covered well, that how frontline workers need to be trained, and how they need to be trained in culturally adapted NCD counseling. So, Vinayagar sir has already covered regarding how to train the frontline workers, but also they need to be trained regarding the NCD counseling part, right? So, also we need to expand telemedicine and AI-based NCD alerts. We need to incorporate the AI tools in the NP-NCD program as well. Right now, we have seen that how the healthcare workers are actually already working through this, but this has to be also incorporated in the program, especially for the tribal blocks. So by doing all these things, also what we need to do in our policy, we need to invest in the local language NCD IC materials. Whatever IC materials we want to publish, we have to make sure that it happens in the local language. Also, we need to create the migration sensitive hypertension strategies. So most of the population, why they are, one of the reason for their hypertension is also that they have a stress that they have to migrate. They do not have any proper this thing. So they have to keep on migrating. So for that also, we need to have certain specific policies. Also, we need to study the intergenerational hypertension risks among the tribal population. This will be again the part of the research part. So research is also important so that we can frame the policies well. So in the last slide, I would like to conclude upon by saying that hypertension in India's tribal population, it requires a dual strategy. First, we need to strengthen the health system. Whatever existing health system is there, that we need to strengthen it. Also, while we have to generate the contextual evidence, on which evidence we have to further improve the health system. So the policy solutions which we provide must be culturally sensitive, geographically accessible to them, and socially inclusive. They should not get offended by whatever things. So we need to understand them well. We need to build a trust around them. So the research also in the tribe, it should be tribe specific, participatory, and action oriented, so that we get the equitable hypertension control. So thank you so much to everyone for your patient listening.
Thank you so much, ma'am, for your comprehensive and visionary session. Your insights offer a clear roadmap for public health action, linking policy, research, and implementation to build a stronger hypertension control framework in travel state like Jharkhand. Thank you so much, ma'am.
Thank
We
you,
now
ma'am.
move to one of the most engaging part of our today's program, that is question and answer session.
Where
When
participants get the chance to share questions, experiences, and
their reflections. Participants may post their question in the chat box or raise their virtual hand to interact directly. It is my pleasure to invite our moderator, Dr. Sudip Bhattacharya, sir. He is Assistant Professor in the Department of Community and Family Medicine in Deoghar, to lead this interactive segment. Sir, we hand over the session to you. I will be asking questions. Actually, due to time constraints, we are not able to reply all. Thank you to participants. They have posed many questions. They have actively participated. We are thankful to them. But there is some time constraint to which we have collected few questions. There will be replying to that question.
the first question which I take is which barrier
is more damaging? Poor system preparedness or no perceived need among the community? Sir, over to you.
Thank you very much. There are many questions, so this is a very interesting question. So the question having two parts. One is any barrier is damaging or not. So yes, obviously any barrier in your life, it is damaging. First thing is that. And what I understand from the question, actually the audiences wanted to know whether system is affecting more to these tribal people or the ignorance or lack of education is affecting more. So as per my limited experience here in AIMS Deoghar, so what we can experience that low education, low health literacy, these are the things, these are the affecting more rather than systemic any barriers. And for first question, this is my response. And any other question, Dr. Abha?
Yes, sir. The next question which we would like to ask is, do we have biochemical validation of sodium intake in
these communities, or are we relying on recall-based assays?
So this is a typical textbook question. So this is also good. Two things are there. We are public health specialists. We are not a molecular biologist or lab scientist basically. So we think about population levels. So already in previous talk, Professor Abhijit Guratne sir has already mentioned regarding excessive salt in diet, either in form of pickles or dried fish or dried vegetables due to their resource constraint and these things, and also their taste. So we think if we ask, the WHO has a questionnaire. So if we go for questionnaire, so it means it gives a 7-point questionnaires are there. So it gives that whether you are taking extra salt, added salt or not, whether you are taking chutney or any type of dried things which is preserved by salt or not. So I think for a initiation of public health initiative or for initiation any public health activity, I think it is more than sufficient to go for this questionnaire based method initially, and later, and obviously the gold standard is 24-hour sodium urinary excretion, but it is very costly, cumbersome and time consuming, and practically it is difficult. So in initial phase in Jharkhand, what we can do, we can go for WHO-based questionnaire method, and later we can do a subsample of that population. Just example, 10% of that population, we can take their samples and we analyze that 24-hour sodium excrete, how much is there. So it can be done. But initially at this phase, AIMS Deoghar should focus on question-based or questionnaire-based estimation of salt. Thank you very much. Any other question?
Thank you
Thank you
so
so
much,
much,
sir.
sir.
No,
Now
sir,
we will move to
our
our. Now we are at the end of the session. As we reach the conclusion of this enriching session, I take great pleasure in expressing my heartfelt thanks to everyone who made this program a success. Our deepest gratitude to Professor Dr. Nitin M. Gangmi, sir, his Executive Director and CEO, and Professor Dr. Harminder Singh, sir, our Dean Academics, who could not come due to his some busy schedule, but his support is always there for us. I would like to thank our HOD, Dr. G. Janvi ma'am, our guest speakers, and sincere thanks to all our distinguished speakers for sharing their expertise and valuable time. A special word of appreciation to all other faculty members who participated, senior residents, junior residents, project staff, and office staff, and who directly and indirectly contributed to making this event possible. Your teamwork, enthusiasm, and commitment are truly commendable. Finally, I thank all our participants and attendees for joining us, making this webinar vibrant and interactive with your questions and answers. One important thing I would like to say here, that kindly fill your full this form to get your certificate. You will get your e-certificate on your email ID. With that, we officially close today's scientific session on emerging health challenges of hypertension among Jharkhand tribal communities. Thank you once again and have a wonderful evening.